Good afternoon, everyone, and thank you for joining us today. Do give us a couple more minutes as we have people joining. We'll start in about 1 to 2 minutes. Thank you. All right. I think we'll get started. Good afternoon, everyone. Thank you again for joining us today. Welcome to the white paper launch webinar, Breaking the Silence, the Case for Action on Fibrosis, MAFLD, and MASH in Asia Pacific. My name is Sapan Vik. I'm from Deloitte, and I will be guiding you through today's session. We are very pleased to have a diverse group of policymakers, clinicians, and stakeholders joining us from across the region. Today's session will focus on a critical and often under-recognized challenge, metabolic liver disease, and how we can collectively strengthen policy response, early detection, and care delivery across Asia Pacific. Let me first briefly introduce myself. As I mentioned, my name is Sapan Vik. I am from Deloitte, based in Singapore. I'm a director as part of our consumer business practice in Southeast Asia. It's a privilege to be part of this important discussion today and to share insights from this regional white paper effort. Let me quickly walk you through today's agenda. We will begin with welcome remarks from Roberta. She's the director of the APAC Liver Disease Alliance. This will be followed by opening remarks from Professor Jacob, who's a leading hepatology expert and head of department at Westmead Hospital. I will then present an overview of the white paper and key findings. Following this, Professor George will share perspectives on best practice, including a case study. We will then hear from Associate Professor Vo, who will share insights on current practice and opportunities for improvement. This will lead into a panel discussion with our distinguished speakers focusing on how we can translate evidence into policy and practice. Finally, we will close the session by Roberta from the APAC Liver Disease Alliance. Let me introduce to you our distinguished speakers, moderator, and panelists. We are honored to be joined by leading experts from across the region. We have Professor Jacob, Head of Gastroenterology and Hepatology at Westmead Hospital. We should shortly be joined by Associate Professor Vo, who's the Vice President of the Vietnam Society of Hepatology. We have Dr. Faisal, with extensive experience in health policy and NCD strategy. Dr. Simone Strasser, Senior Staff Specialist in Hepatology, and Associate Professor Sakarin from Thailand. And of course, Roberta, who will open today's session. Without further delay, I would like to invite Roberta to deliver the opening remarks. Roberta, over to you.
Thank you. Thanks a lot, Sapan, and good morning, good afternoon, depending on where you're joining from. Welcome, everyone. My name is Roberta. I'm the director of the APAC Liver Disease Alliance, and on behalf of the Alliance, thank you for joining us. So we have an important session today. Number one, because we launched our first paper on fibrosis, MAFLD, and MASH, but also because we officially open a new chapter focusing on metabolic liver disease at the APAC Liver Disease Alliance. So let me start with who we are and why we're here. So the APAC Liver Disease Alliance is a neutral multi-stakeholder platform that has been created in 2023 and is working across the Asia Pacific on liver disease policy, which includes viral hepatitis, hepatocellular carcinoma, and increasingly the focus of today's session, MAFLD, MASH, and fibrosis. We bring together clinicians, policymakers, patient advocates, and industry partners with one common goal, which is to reduce the growing burden of liver disease in the Asia Pacific. What does that mean in practice? That means three things, okay? Number one, we raise awareness, building the evidence base for why liver disease deserves more attention from the public and from decision makers. Number two, we advocate, pushing for political commitment and importantly, for the financing that makes sustainable patient access possible. And number three, we work on policy development, supporting government officials across the region to build national liver disease action plans and to embed early screening, surveillance, and treatment into their health systems. So we do this by speaking with one voice across a coalition that includes every stakeholder and decision makers working in liver health ecosystem. This is exactly the kind of room we have today. And over the past few years, we have been running regional and country level programs across multiple territories, including Vietnam, Thailand, Singapore, Australia, Taiwan, Philippines, Pakistan. For sure, I'm forgetting some. We have been working directly with the national health authorities on viral hepatitis and hepatocellular carcinoma. We have convened policy roundtables, supported peer-reviewed publications, and importantly, we have built the relationships with ministries and authorities that finally decide whether good evidence also becomes good policy. Why I'm sharing this? I'm sharing this because this same approach is what we will now apply to MAFLD, MASH, and fibrosis. And actually, the case for applying that is very urgent. What we learned from the study that you are about to hear is that nearly 1 in 4 adults globally lives with MAFLD. And in APAC, the picture is even worse because we have very high rates of what is called lean MAFLD. What does that mean? It means that people who develop serious liver disease without obesity, making diagnosis difficult. And this means also that these patients are frequently missed until the disease is very advanced. Yeah. We have other issues, such as, for example, health systems that are still oriented to respond to late-stage diagnosis and disease rather than trying to find the disease early. And also, as you will hear, across the 9 territories that we have assessed in this paper, not one has a costed national action plan for MAFLD, MASH, and fibrosis. And screening still so happen, very, very often by chance. Yeah. Diagnostic pathways are fragmented between specialists and primary care. So these are just some of the gaps that this paper, Breaking the Silence, has highlighted. But we have the good news, okay? The good news is that we already have the tools. We have validated non-invasive tests that can stratify fibrosis risk without a biopsy. And we also have existing diabetes and obesity care pathways that fibrosis, MAFLD, and MASH will simply leverage. So what do we miss? We miss the policy ownership. We miss the financing and the political will to really redesign the care pathways around early detection rather than late-stage diagnosis. So This paper is the result of months of work from our advisory panel of clinicians and policy experts across the region, from our territory leads and from our partners at Deloitte who have led this analysis you are about to hear. So really, I want to thank everyone for their work. And on our side, at the Alliance, this is really our approach will really be to start from the evidence that is about to be presented and then design toward action. And I want to be very clear, right, that the point of today is not just to launch a paper and then move on, but it's really to start a conversation in this room today. And this conversation will lead to real policy improvement. And ultimately, what we all care about, this will lead to better outcomes for patients across the region that are still, they currently are at risk and they still don't know it. With that, I will hand it over to someone who needs very little introduction in this field, Professor Jacob George, for the formal opening remarks. So Jacob, over to you. Thank you. Thanks a lot, everyone, for being here.
So thank you, Roberta, and good evening, everyone, and thank you for the opportunity to be part of this important discussion. For me personally, the MAFLD journey has been going on over the last 20 plus years. So it is really the culmination of a lot of this work to join colleagues, policymakers, and health system leaders from across the Asia Pacific to launch this white paper, Breaking the Silence, the Case for Action on Fibrosis, MAFLD and MASH. I think this is a timely initiative as these conditions are no longer peripheral concerns. They are rapidly becoming a major public health challenge across the Asia Pacific. And the liver really is at the center of cardiometabolic health. What makes this challenge particularly urgent is that the burden is both large and also equally, it's largely hidden. A significant proportion of adults in our region are affected by metabolic liver disease, driven by rising rates of obesity, type 2 diabetes, and broader metabolic conditions such as hypertension. Yet, for many patients, the disease progresses quietly, including in patients with compensated cirrhosis. In the early stages, individuals often feel entirely well, and as a result, they frequently come to medical attention only when they've already developed advanced fibrosis, cirrhosis, or its complications. By then, the opportunity for early, simple intervention has often been missed. This brings us to one of the most important issues we face today. We are diagnosing patients too late. Across many health systems, not just in the Asia Pacific, but the world over, there is no consistent or systematic approach to identifying patients earlier in their disease course, particularly those who are more likely to progress, and trying to intervene to prevent progression. Liver health, as you know, is not fully integrated into routine care pathways such as primary care or diabetes management, despite the clear overlap in patient populations. And as many of you know, Jeff Lazarus has led looking at the policy preparedness across the globe, and his data are quite significant, showing that most countries are not prepared for the tsunami that we're experiencing. So as a result, many individuals at risk are not being assessed until much later than we would like. At the same time, it is important to recognize that we're no longer limited by a lack of tools. We now have access to simple, non-invasive methods that are elucidated in all guidelines that allow us to identify liver disease earlier and more efficiently than ever before. These tools can be used in routine clinical settings and has the potential to transform how we detect and monitor disease. However, the challenge today is not the absence of these technologies. It is ensuring that they're consistently adopted, appropriately used, and integrated into everyday clinical practice. In many settings, uptake remains uneven due to poor awareness, practical constraints, or gaps in financing and system support. Another key issue that I'll illustrate in my next talk is the fragmentation of care pathways. Even when patients are identified, the journey from initial detection to confirmation, referral, and long-term management is often unclear. Primary care providers may not always have clear guidance on when to investigate, when to refer, and patients then feel that they don't engage with the health system. From the specialist perspective, they can become overburdened if referral systems are not well designed and targeted so that the patients who need specialist attention most are referred. So this really highlights the need for more structured, coordinated care pathways that link early identification with appropriate, and the key word is appropriate, management. We must acknowledge that these conditions still face a policy visibility challenge. In many countries, MAFLD and MASH are not yet prioritized at a national level. Responsibility is often spread across multiple areas, whether it be liver disease, metabolic health, diabetes, cardiovascular disease, or other non-communicable disease programs. Without clear ownership, it becomes difficult to drive coordinated action and meaningful system change. So why does all this matter now? Because if we continue our current path, we will see a growing burden of advanced disease, including cirrhosis and liver cancer, alongside rising healthcare costs. The reality is that the greatest burden, both clinical and economic, occurs at the late stage of disease. So our best hope for tackling the disease is early detection and management to prevent progression. This means that early identification is not just better for patients, but also essential for sustainability of our health systems. So there is a clear need for a shift in how we approach these metabolic conditions. We need to be less reactive and treating advanced disease to identifying and managing patients earlier in their journey. This includes better use of non-invasive tools, integrating liver health into routine care, strengthening pathways and linkages between primary care and specialists, and ensuring that these issues are recognized and prioritized at local and national policy level. This white paper we are launching today provides a strong foundation for this conversation across the Asia Pacific. But ultimately, the key challenge is to translate this white paper and this evidence into practical change in policy, in clinical practice, and in how our health systems are organized. So I really very much look forward to the discussions ahead and to hearing how we can collectively move this agenda across the Asia Pacific. Thank you very much.
Thank you very much, Jacob, for those insightful opening remarks, and also Roberta. I will now walk you through the key insights from the white paper. This work reflects a collaborative effort across multiple experts and territories with the aim of providing a structured and comparative view of how health systems across Asia Pacific are responding to metabolic liver disease. Let me begin by briefly outlining the methodology behind this white paper. The study assesses the fibrosis, MAFLD, and MASH policy and care landscape across 5 key domains. First, national policy and planning, including whether countries have clear strategies, funding, coordination mechanisms, and registries in place. Second, prevention and screening, looking at whether high-risk populations are identified and whether screening is supported and implemented. Third, diagnosis and healthcare system capacity, including availability of diagnostics, workforce readiness and access. Fourth, treatment, monitoring and access, covering care pathways, treatment availability, and long-term management systems. And finally, advocacy, awareness, and education, which are critical enablers of early detection and system response. Across these domains, we assessed a range of indicators to provide a structured and comparable view of system readiness. This is a regional study with more focus on 9 territories across Asia Pacific. This white paper is not only built from our own research. Indeed, this work was informed by a highly respected advisory panel. We engaged 14 experts across 9 territories representing leading hepatology centers, clinical institutions, and policy expertise. Their input was critical in validating our findings, ensuring that the analysis reflects real-world practice, and strengthening the practical relevance of these recommendations. We are extremely grateful for their contributions to this effort. I will now move into the key insights from the analysis. In particular, we focus on what these findings mean in terms of urgency for action across the region. Let me start with the clinical burden. Metabolic liver disease represents a rapidly growing and highly under-recognized challenge across Asia Pacific. First, prevalence is both high and increasing, affecting approximately 25 to 40% of the adult population. Despite this scale, a large proportion of cases remain undiagnosed, particularly in early stages. Second, an important clinical insight is that fibrosis stage, not just the presence of fatty liver, is the key driver of outcomes. Around 20% of patients progress to MASH, which drives fibrosis progression and leads to more severe outcomes such as cirrhosis, liver failure, and liver cancer. Third, disease progression is largely silent. Most patients do not recognize it in early stages, which means diagnosis often happens when complications have already developed. This creates a significant hidden burden at population level. Finally, there's a strong link with cardiometabolic conditions, including diabetes, obesity, and cardiovascular diseases. These comorbidities further accelerate disease progression and increase complexity of care. This clinical burden translates directly into a substantial economic and social impact. The key point here is that costs are heavily concentrated in advanced stages of disease. As patients progress to advanced fibrosis and cirrhosis, healthcare utilization increases significantly. At the same time, there are major indirect costs, including productivity losses and long-term social care needs. What we see is clear imbalance, relatively lower investment in early-stage management, but rapidly escalating costs later in the disease pathway. This further reinforces the importance of shifting towards earlier detection and intervention. Taken together, these findings point to a clear conclusion. Current approaches are insufficient. There remains a large undiagnosed population, increasing multimorbidity, and rising system burden. Importantly, MAFLD and MASH are often not addressed explicitly within national policy frameworks. This highlights the need for a more dedicated policy response. Second, care systems need to be strengthened across the entire continuum, from early identification to structured referral pathways to long-term management. Third, there is still limited adoption of diagnostic technologies, despite availability of simple non-invasive tools. And finally, delays in action will widen inequities and place further strain on healthcare systems. Overall, there is a significant gap between disease burden and system readiness, which underscores the urgency for coordinated policy action. To assess the system readiness, we developed a scorecard across the 5 domains. What this shows is that there is substantial variation across territories and across domains. A few key directional insights emerge. First, many territories have a strong NCD policy base, but MAFLD and MASH are not prioritized as standalone focus. Second, early identification is increasingly recognized as important, but implementation remains limited at scale. Third, diagnostic capacity is improving, particularly in higher resource settings, but access remains uneven. Fourth, treatment readiness is advancing, especially with emerging therapies, but system enablers such as financing and care pathways are still lagging. And finally, while advocacy is growing, overall awareness and education remain inconsistent. Bringing this together, we see a consistent pattern across the region. There is a strong policy foundation, but limited disease-specific prioritization. Early identification is understood, but not systematically embedded. Diagnostic capabilities improving, but not translating into real-world uptake. Care pathways remain fragmented, particularly between primary care and specialist services. And awareness, both public and within primary care, remains a major constraint. Overall, this means that health systems are still largely reactive rather than proactive in managing metabolic liver disease. Based on these findings, the white paper outlines a set of prioritized recommendations. At a high level, these focus on three key shifts. First, strengthening the policy prioritization, including embedding MAFLD and MASH more clearly within national strategies. Second, moving towards structured early identification, particularly targeting high-risk populations and integrating this into routine care. Third, scaling the use of non-invasive diagnostic tools to enhance the accessibility and prioritize those at greater risk of progression. In addition, there is a need to standardize referral pathways, build data systems and registries, strengthen integrated care models, and prepare health systems for emerging therapies. Importantly, these recommendations are prioritized by both impact and feasibility to support practical implementation over short, medium, and long-term timelines. With that, I hope this provides a clear view of both the scale and of the challenge and the key gaps in the system readiness across the region. The natural next question, of course, is what does good look like in practice? And how can health systems begin to translate these insights into real-world implementation? To explore this, we are very fortunate to have with us Jacob, who will share perspectives on best practice while highlighting opportunities for further improvement. Jacob, over to you.
Thanks very much, Saphan. And can we have the next slide? So what I'd like to do in the next 10 to 15 minutes is really talk about the case study for Japan. Everyone across the world, I think, appreciates that Japan, in terms of a response at all levels for liver cancer management, is really stellar, better than any other country in the world that I know of. But I'd also like to now just show you the case study for the data-driven specialist-led model for MAFLD and MASH and fibrosis management. And I want to emphasize that while Japan has done a lot of things that we can all emulate, it's not all there because this is a disease that's so common, and really a big push has to be on integrating primary care where most of the management of MAFLD and MASH should occur, with really well-developed care pathways into specialist care for the patients that need specialist care. So in terms of Japan's policy response or the practical response to MAFLD, MASH, and fibrosis, as we all know, partly with the hepatitis C and liver cancer epidemic that they've had for the last 30, 40 years, it is a very mature but specialist-driven system with very strong diagnostic capability and very strong liver leadership. So what we know that happens in Japan is that the system has high diagnostic infrastructure, established clinical expertise, and we are beginning in Japan to move to a phase of risk stratification. And at the back end, it also highlights how the data systems and specialist capacity can drive disease management, but it also illustrates the need for stronger population-level identification pathways. Next slide, please, Saphan. So this is the evolution of the MAFLD and fibrosis management pathway in Japan. Phase 1 is a specialist-led liver disease model that was there pre-2010. And there was, with the liver cancer epidemic there and hepatitis C, they had strong hepatology capacity, national investment into specialist care, but a focus was predominantly on advanced liver disease, cirrhosis, and pre-cirrhosis. And then in the next phase, after 2010 and beyond, there's been a system expansion and infrastructure strengthening. So that was characterized by scaling of tertiary care capacity and capability, development of clinical care pathways within specialist care settings. So again, we can see that, for example, in liver cancer, where multiple specialists are involved in treatment. And then there's been growing integration of liver disease management within broader chronic care systems. And in the last 10 to 15 years, what we're seeing is the emergence of metabolic-driven liver disease. And in Japan, they've increasingly begun to focus on recognition of MAFLD as a public health challenge, trying to get a policy response for MAFLD. And so it's shifted, but the system was already ready because of the hepatitis C epidemic. So we could go from infection-driven liver disease to lifestyle-related liver disease. And now we're moving, because this is such a common disease affecting up to a third of the population, we need to transition forward to a fibrosis management-based algorithm where all patients, 1 in 3 are going to have MAFLD. They need to be assessed in terms of fibrosis, risk stratification, and then referred appropriately. And to enable these, a lot of things need to happen. We need to adopt non-invasive fibrosis assessment. We need to upskill the whole population, really, of the medical workforce and the health workforce into metabolic screening of high-risk populations. And we need to understand and we need to advocate to policymakers that a clear clinical and policy anchor is fibrosis. And we need to, in the day of AI and big data systems, use these data sets and real-world evidence to inform disease management, to advise on policy, and to improve care pathways. Next slide, please. So when you look at the strategic and policy architecture, you can think of it as 4 pillars. Pillar 1 is early detection and risk stratification, which means we need to identify high-risk individuals, adopt NITs, whether they're imaging-based or blood-based, and shift really from opportunistic diagnosis to structured diagnosis. And most patients will have their first linkage with the medical system at primary care. And we need to increase awareness and embed structured diagnosis of liver disease and fibrosis into primary care. Secondly, we need to strengthen diagnostic capacity. So in some countries across the Asia Pacific, these technologies are available. But as Sapan previously mentioned, the availability of these techniques are a bit variable across the Asia Pacific, and we need to increase that. We need to integrate and inform everyone from primary care to specialists who are only doing colonoscopy, for example, or endocrinologists or cardiologists, to integrate fibrosis staging. And we need to use imaging and biomarker-based responses. So specialist-led management really looks at the hepatologist, but with a disease that is so common, we need to ensure that only the patients where our expertise, our specific expertise, is useful are the patients that are referred, so that most of the patients can remain in primary care, monitored, fibrosis assessment and stratification occurring, at 1, 2, or 3 year intervals, depending on the clinical case, and then appropriately refer with an established referral pathway to specialists. And at the back end, we also need a data systems and policy enablers. So national data sets, hospital data sets, statewide data sets to track health utilization and disease burden, to inform practice, and increase the use of real-world data in informing policy decisions. And this really becomes the foundation for evidence-based policy refinement and planning, which we are increasingly able to do in this era of AI and big health data systems. Next slide. Okay, so when we think about what Japan does well, we can think about what they've done well at a national level in terms of policy direction and health system performance. They've already got that embedded through their response to hepatitis C and liver cancer. And they do use national level data for monitoring and planning. And many other countries in the Asia Pacific do it, including, I know, China, Korea, Taiwan, Hong Kong, Australia, and many other countries. And the specialist and tertiary care level is at the core of advanced disease management, particularly when complications occur. And many hospitals and centers in many countries now have excellent hepatology centers and tertiary hospitals that are responsible for diagnosing and staging fibrosis and treatment planning and disease monitoring. And they do have a high concentration of expertise and diagnostic imaging technologies. What about referral and access pathways? So even now in Japan, patients often are identified through routine clinical pathway encounters, and they're referred to specialists for confirmatory diagnosis and management. And I put it to you that in the longer term, we really need to have diagnosis and early management in the hands of primary care. And so the referral pathways really should be based on fibrosis and staging fibrosis and risk stratification, and then referring the appropriate patients across to specialists. So Japan has a strong hospital and specialist-centric model, excellent capacity for diagnosing and managing advanced disease, but less developed primary care-driven screening and longitudinal systems management. And I think really to be the exemplar, they need to also devolve some of this management of MAFLD into primary care. Next slide. So this is really looking at the care model across the disease continuum. There are really 4 pillars: high-risk population screening, diagnosis and fibrosis staging, and if I had my way, this would be done in primary care. And then we need treatment and monitoring, and that really needs to be a shared care model between the specialist and the primary care physician, particularly because this disease affects 1 in 3 people in the world. And then long-term management should be included in specialist care settings. So there are some key gaps. Sorry, there's fragmentation between early risk identification and specialist referral, limited structural pathways, and reliance on patient entry into the system rather than proactive identification. Sorry for the coughing, guys. Next slide. I think this is my last slide. So Japan does some things very well. Excellent specialist capacity, excellent diagnostic infrastructure, and it's got a robust hospital-based healthcare delivery system with high diagnostic and treatment capacity. I think the challenge is that it needs to consistently translate this into early detection, and that means it has to be implemented in primary care. Now, across the Asia Pacific, we obviously need to ensure equity and balance and reduce the disparities between regions and settings. And we need to, again, as I emphasized, integrate primary care into specialist care. And right now, Japan, it is a key challenge. So I think, in summary, Japan demonstrates that infrastructure readiness and a good specialist health system is insufficient unless you have a structured pathway for population level. This is the key. In MAFLD, we're talking of a disease that affects 1 in 3 people. We need population level screening, risk stratification, and care integration. Next slide. So I think in moving to the discussion later on in the program, the key learnings from Japan is that specialist excellence is a crucial foundation. Japan gets a big tick for this. Fibrosis risk stratification provides a more reliable and actionable framework for a disease that's very common. I think it's done well in specialist care, but I think Japan probably scores a 5 or 6 out of 10 for that. Data infrastructure is a critical enabler, and I think Japan does very well on that. 8 on 10 for that from me. High diagnostic capacity, they do have, but it needs to be leveraged to systematic screening pathways for high-risk population. Again, read that this has to be in primary care. And we need to transition from reactive, specialist-led care to a proactive, population-based management. So that is essential to reduce disease burden. And we need overall to have integrated models linking screening, diagnosis across the management pathway and the care pathway to fully capture at the most efficient price the benefits of the existing health systems. Thank you.
Thank you, Jacob, for these valuable insights. Your presentation clearly showed that progress depends not only on having the right clinical tools, but on having the right system conditions, policy ownership, clear pathways, diagnostic adoption, and coordinated care models. While we had originally planned for Professor Vo to be with us due to an unforeseen urgent situation, he would not be able to join us today. But not to worry, we would proceed with the panel discussion. And what we have heard across the presentations is a very clear narrative. The burden is rising, the gaps are well recognized, and there are emerging examples of how to move forward. The key question now is how we translate these insights into practical action across different healthcare system contexts. With that, we move into our panel discussion. I'm very pleased to invite our distinguished moderator and panelists, Professor Strasser, Simone Strasser, who will be moderating the discussion, Jacob, Sakharin, and Dr. Faisal. Together, we will explore how to strengthen policy prioritization, embed earlier identification into care pathways, and address system readiness gaps across the region. Simone, I'll hand over to you to lead the discussion.
Thank you so much, Sapan, and it's a delight to be with everybody and as we go forwards in this discussion. And I think we've got an incredibly important framework to base our discussion on. We've got the case study from Japan with Jacob's tick scores for some and not for others. But it really gives us an opportunity to talk about a few really, really key areas, as Sapan has highlighted, and particularly look at the policy prioritization around the region. And we've got experiences that are going to come from experts across the region now. We'll look at some of those early detection and care pathways, and we'll look at our system readiness and the potential future landscape because it's rapidly evolving. So I would like to go to each of our panelists and to really to open up and talk about particularly policy and how we prioritize policy. And with a key question about, from your perspective, why has fibrosis and the MAFLD MASH story, which has really been evolving for some time, but particularly over the last 5 to 10 years, not yet been prioritized at national policy level in many of the countries across the APAC region, and what needs to change? So, Sakharin, I will ask you first to give us your insights into why have we got these gaps in policy, and what can we do about changing the narrative there?
So thank you, Simone. So I think because right now for fibrosis in the past, we don't have the, like globally approach, original approach. We just receive for the last guideline related for the two-step approach, maybe study for in multinational guideline also mentioned about the two-step approach that we need to looking for some, cheaper test like a FIB-4, and then you can identify for the high-risk patient and you can go forward for the transient elastography. However, for the transient elastography, as you see that in many countries, let's say like even though in a high income country in the western side, they are also not available in every hospital, and also the price of the machine and also for the maintenance is also really high as well. That's why I think government still need to look again and look beyond the better test for the fibrosis assessment, because if we stick on only imaging technique, sometimes it can be the gap to do like the screening. That's why I think to be the mass screening maybe but based test, it should be better for identify high risk patient.
So where do you think the gap is, though, at the government level and the policy level with that? So, clearly we need those tools once we get to the patient level and the diagnosis level. But do you think there's engagement at a government level that this is even a problem?
I think if we would like to engage for the government or policy maker level, we also need to look further for the cost effectiveness data as well. Let's say like if you have a very expensive machine and how you can prevent one patient to pass away from the cirrhosis or liver cancer or whatever related with the liver complication. That's why we also need to look further for the cost effective and talk with the stakeholder about, how to reimburse to do the mass screening to the patient who are at risk for the cirrhosis from MAFLD.
Thank you. So Faisal, you're working within the health department in Malaysia. Where do you think these issues are in terms of recognizing the problems and starting to unwrap the policy needs here, even as we get to the community level?
Right. Hi, good morning, good afternoon, good evening, everyone. Taking it at the higher level, policy level, if I were to look back with the increasing burden of non-communicable diseases, as it were, overall, at least in Malaysia in the 1990s, it was the champion. So who was the initial champion who had the strongest, doing the strongest advocacy work that determines in a way which policy gets more attention within the NCD space. So it is a very crowded space if you think about it, not just NCDs, you have your communicable diseases and everything else. So even just within the NCD, it's already crowded. So I feel that it was driven very much by who had the loudest voice. That's one important factor. The other thing that can influence countries such as Malaysia is what WHO advocates, being the lead agency under the UN, global agency under the UN. So that can influence what gets more attention at the policy level space. The other thing, I suppose, is that when you don't talk about it, most people wouldn't think about it. That's one. And if only the specialists at the tertiary levels are talking about it, then you will see it more like a specialized condition. Not so much everyone has it, only a select few will have it. So these are all a matter of perceptions, which actually have been addressed in the white paper the reason why we're having this conversation is, in fact, one is to raise awareness, and the other thing, I hope, if there are champions among the listeners, now is the time to make noise and to ensure that it is in the radar of the people who are making decisions, what gets the attention of the health minister. I'll stop there, Simone.
Thank you, Faisal. Jacob, we've got policies in obesity and diabetes and cardiovascular disease. How do we get MAFLD up to the policy level in terms of recognition from governments, either within Australia or within the region?
Yeah. I think Faisal actually put it nicely. I mean, we need advocacy. And one of the strongest things that government listens to is having patient advocacy groups and patients pushing for national change, national strategies. Politicians respond to patients. The other aspect, I think, is that politicians also respond to data. And traditionally, with liver disease, they did respond at policy level to hepatitis C. They did respond to malignancies, other malignancies, etc. But a lot of it is because, if you look at the Japan response to hepatitis C or China today in their response to hepatitis C and hepatitis B, because there were lots of people succumbing from end-stage liver disease, either it's cancer or decompensated liver disease, they had the data. MAFLD as a condition that's, it's got a slow progression. It takes, 30 plus years. And the rise in the obesity rates was really since the 1980s. And most of the patients at the initial stage of the epidemic with MAFLD were really dying from diabetes, CKD, and the big elephant in the room, cardiovascular disease. They were killing more people. But what's happened in the last 40 years, I think, is that the cardiologists have got very good at stenting. So it's very difficult nowadays to die from cardiovascular disease if you get to the hospital. And similarly, we've got this plethora of drugs for diabetes, and we've got dialysis. And so a lot of these patients with these other metabolic conditions now are living longer and getting decompensated liver disease, cirrhosis, liver cancer. And I think we can all do that data. So we've done studies in Australia on modeling the epidemic to 2030, showing the increase in liver cancer, liver failure, cirrhosis, etc. And I think if we can get advocacy on one side and data on the other side and put it to government, they will respond because in the end, they want to work for the benefit of their population.
Thank you. So another area here that we haven't touched on yet is the role of industry. We've talked about the role of governments, we've talked about the patients and advocacy, but this is an emerging area where there is now an industry, finally. There's starting to be therapeutics that are coming into our space, and we've certainly seen the role of industry in terms of raising awareness and getting policy change in terms of funding of therapeutics, for instance, or funding of diagnostic tests in the viral hepatitis space, in cancer space, in diabetes care, hypertension, etc. Where do you think industry is in this space? And I might ask Sakran about what's happening in Thailand in terms of industry now coming into this space to really raise that awareness level now that we're starting to get therapeutics.
Yeah. So right now in Thailand, we already have the medication approved for MASH. However, unfortunately, it's still not allowed for reimbursed yet by the government because the indication also have other indication, let's say like obesity, that totally cannot reimburse. That's why, right now it's a little bit news in the society about we have the new medication to treat the new disease, as Jacob mentioned, to compare with the liver cancer or hepatitis B and C. The MASH is like a very new disease that not only for the government, let's say like our colleague, like cardiologists, sometimes it's a little bit difficult to convince them to screening people who are at risk for MASH and send the patient who have the high risk of advanced fibrosis to us. That's why I think we need to, work harder, especially for the awareness, not only for patient, but we have to do in all aspects. Let's say like including for our colleague and like a patient awareness also. That's why I think if we have the strong enough for the patient awareness, we can create patient advocacy like NGO who are recognized about the burden of MASH that could be happen to them, even though it's a long run, but it can happen the scary disease like a liver cancer or HCC someday. That's why I think it may be more powerful to convince the stakeholder to listen for the screening or, have the better for the care pathway.
Thank you. Any comments from anyone else about really that role of industry? Faisal, have you got
Before I answer that, Simone, going back to the advocacy,
yes.
I totally agree with Jacob, the role of civil society. Of course, in some countries, middle-income countries, civil society is not as strong as the high-income countries. But I truly believe, and I agree with you, that it's not just top-down, but you need a bottom-up as well. The reason why I'm bringing this, Simone, is when it comes to advocacy, please do not advocate for another vertical program, because that's the danger if people see it as another vertical. A lot of
Can you explain what you mean by vertical program?
It's as if, okay, you have your, traditionally, even in Malaysia, you have your diabetes program, you have your cardiovascular disease program, and then you have your hypertension. This was way back in the 1990s. And over time, it has become integrated. So I see a lot of countries moving forward, even in Malaysia. Now we are talking about metabolic diseases rather than separate. So the danger is not to pitch it, because advocacy groups are advocacy groups. Sometimes they're not really medically trained. I do not want it to appear like it is another vertical. Because then when you say vertical, people think of a whole set of resources required, not just manpower, money, systems, everything else. So it needs to be pitched, I use the word pitch, as part and parcel of an existing program. For example, so it has to be integrated. Maybe it's a complication of a disease, for example. So it doesn't seem like, oh, I'm going to create another fibrosis MAFLD program. Okay, anyway, going back to your earlier question about industry, this gets a bit tricky for me. Because we talk about commercial determinants of health now. I mean, that's becoming more people are talking about commercial determinants of health. If you have transparent governance, I think that's much easier to manage. So there is a prerequisite. If you have a transparent governance where you can ensure that when involved pharmaceutical, I just limit the industry to pharmaceutical because it can be medical devices as well and a whole set of other industries. If you can ensure that the involvement, like for innovation or for capacity support, doesn't undermine or determine policy priorities, for example, or it doesn't create product-dependent pathways. So I think those are, we need to be cognizant, maybe not so much in the upper high-income countries, but in some countries where they have a bit more influence compared to others. So that's a separate discussion. Someone, let's not go there. But I welcome, but as long as there is transparent governance and doesn't create any conflict of interest.
No, I agree. And I think we've got to be aware that they are players in this place. I take your point completely that we're talking about the same patients in all of this. The same patient that's got the obesity, the heart disease, the diabetes, and now as an emerging issue, the liver disease. And it shouldn't be directed by just one focus, I think. Jacob, have you got any additional comments on that and particularly?
No, I mean, I think the reality is that pharma is here to stay, and they do bring innovative drugs, and innovation in the drug space is expensive. And at the end of the day, they are a company, and yes, they do have a profit motive. But where they can be very useful, and I agree completely with Faisal that they should not be influencing policy. And I think most countries in the policy space, they really want to be agnostic of commercial determinants and really look at the end beneficiary, which is the patient. And so I think they do have an important role in awareness. And I think that's very important, and showing the scale of the problem, etc. But I think at the policy level, fully agree that it needs to be at arm's length and transparent, and it should be, it should be a response. The data that needs to be provided to the government really should be based on public health data, clinical data, research data, basic science data. All of that's got to be presented and show that it's affecting a significant proportion of the population. Particularly what governments are interested in is diseases that kill people. So they want to prevent liver-related deaths or liver cancer or melanoma or bowel cancer that they can see. So we need to get that data settings right. But industry does have a role.
Yeah, and we certainly can't ignore that. Thank you all. I'd like to move on now to really start talking about barriers in terms of early detection. And a large part of the white paper is really talking about that we're diagnosing too late. What can we do to start ramping that up in early detection so that we can bring effective interventions in early to prevent those downstream consequences of advanced liver disease, liver cancer, etc. So what is it going to take, particularly, and I'll take this to Faisal, I think, how can we operationalize from a Ministry of Health point of view, from a government point of view, that early fibrosis detection in routine care? Clearly, for most of the region, we can't rely on specialist care for this. There's way too many patients and not enough specialists in many, many countries across the region. And as Jacob pointed out, in Japan, where there is a specialist model, they're failing in this sort of community level engagement. How are we going to operationalize that from a holistic government point of view?
Oh, that's a really tricky one for me to answer, because at least in Malaysia, what we have managed so far is to get it on the policy space. So I think we have managed to get it there in the discussions to be part of the integrated NCD strategic plan for the country, means putting it in within the obesity, diabetes kind of conversation. When it comes to screening, I think the first question for us in Malaysia, what's next? No point, even if we have a good tool and we can stratify them to low, medium, and high risk, whether our system can cope with that kind of diagnosis, as it were, because previously it was always seen as, if you're suspicious, you refer to specialists. So that model cannot. That's the whole point we're having this discussion. But even if you can stratify them, is there another level of intervention, or is it just monitoring them? And how do you communicate this to the patient when we know by and large they are asymptomatic throughout this part of the pathway until, if and when, they develop complications later on over many years? So it is, again, looking at capacity of health systems to accommodate this additional layer. For example, even for diabetes, let's just say for diabetes, the common complications, we are already struggling for your eye complications, for your kidney complications, because these also happen in stages, right? You can detect early and you can try to intervene early. So these are, if I use that as an analogy, even that also is something that, at least in Malaysia, we are struggling to ensure that people comply to their follow-ups, and even the healthcare providers are doing what they're supposed to do, which is clearly stated in the clinical practice guidelines. Now you're adding another thing to do. So it is, again, how do we ensure, firstly, that people are doing what they're supposed to do even within existing work processes, and we are making steps. We have our audits, our quality assurance programs, at least at the primary care within the public health sector, to ensure that people are complying. But then the next, do we have the resources to do this? And not just the screening, because the screening is relatively easy with the tools that we have now, but the what's next? Because it's not just about the screening itself, but making sure that it is actionable, for one, and making sure the most vulnerable population who are least likely to engage with us, will come for that particular screening over time. Because this is, you're talking about over time, it's not just a one-off thing. And I've said, even with the current work processes within the diabetes, I just use that as an example. Because we talk about obesity, that's a different ballpark, because 1 in 2 of adult Malaysians are obese. So you're talking about how.
Can I ask, what does screening look like in the obesity setting in Malaysia?
So so that is something that we're trying to do as well, because the danger is when you have so many adults who are overweight and obese, and you don't really have much in terms of options to offer. available to you. And when the belief is for most people living with obesity is not a disease, I feel well, so why do I want treatment? So that is so it's not just about I think for me, Simon, it's not just about the supply side. I mean, we can do it. Is it also the demand side, whether people feel that this is worthwhile? No, it's important to do, not worthwhile, but worthwhile to do. And we are struggling even with people living with obesity, let alone something that we are discussing today, which by and large are asymptomatic by nature.
Thank
I'll
you.
stop there.
Thank you. Jacob, how are we doing in Australia, do you think, in terms of getting that early diagnosis message out and starting to become normalized? And how does that translate, I guess, into other countries in the region?
I think Faisal very nicely illustrated the complexities of trying to do something at population level. And as he said, if we can get policy implementation, that becomes important. But then at the national level, what we've done in Australia is we've got some national guidelines for MAFLD, but just having a guideline that's on the web or in an article doesn't change practice for the population. And you need systems to actually ensure that those guidelines are implemented. And, that varies from talking to GPs, webinars, talking at meetings, etc., small dinner meetings, all of that needs to happen to change the care. But then we also need, at a very local level, even more than a national level, at local level, we may need to modify it. So it's good that we have a two-pronged test in our guidelines with a FIB4 first, and then we're talking about a second-line test such as a FibroScan. And we say all patients with a FIB4 more than 1.3 should be referred. But the reality of that one is that's a lot of people for the number of hepatologists we've got. So we then have to modify it at the local level, at a hospital level, to say, okay, we definitely want to see, much higher FIB4s in the hospital, and that if we end up having a FIB4 threshold of 1.3, then maybe you need to have nurse-led models of care where you just do a FibroScan, send them back to primary care, and say you need this repeated in 2 years or 3 years, etc. So you have to actually adjust your policy, your guidelines to the local environment, because the supply side becomes very important, as Faisal was saying. How many hepatologists are there? Are they interested in looking after this disease? Can they actually manage the disease, etc.? And then, even if they can assess and diagnose, is there, lifestyle intervention for all chronic diseases? I think should be the purview of primary care, not specialist care, because just, virtually everyone needs it. But then you then think, okay, what can a specialist provide? Yes, in hepatology, we can provide things for patients with cirrhosis or varices or decompensation. Those are a no-brainer. They should be referred. But what do you do if someone has a FibroScan of 10 or 12 and you don't have a drug that is freely available? So I think we need to think about all of that to really make actionable change. And hopefully, over the next few years, many of these drugs will be approved. I mean, we're very lucky in Australia that we have a universal health system. And so, health should be for everyone, not just for a few select who can afford to pay. So I think in Australia, we're hoping to achieve that.
Thank you. Sakran, can I ask you in Thailand about this interface between primary care and specialist care, and how that's going to be able to fill that early detection of disease space in your experience?
Yeah. So I think we quite new for this system, because for the care pathway that we try to communicate to the primary care or endocrinologists or people who are taking care patient with diabetes and obesity, we try to communicate them that you can use the tools like the FIB4 that you can do in your own practice, and you can triage who you can take care with you or who you should be referred to do like a further investigation. We have many center in our country that have FibroScan. However, in the rural area, it's difficult for them to send the patient out for or even though refer to the patient for the patient to the small village to the big center for do just only the FibroScan, and they may need to drive more than 3 or 4 hours to go back to their hometown. That's why I think for the system is also have some room of improvement. Let's say like we also need to looking for the awareness that I mentioned before. We also need to communicate to all aspects, not only for the physician only. We also need to communicate to our patient also to aware about this slow progressive disease. And also we need also to provide the good system to follow up of this. Let's say like if we have some learning for diabetes. Right now, in our health policy, we try to have the better care for diabetes. Like a patient who have diabetes need to do like eye screening for diabetes retinopathy. That's why in some center they say like to do the system to just take a photo of the patient who have the diabetes and send it back to the cloud system and have ophthalmologist to do the screening and call patient back that who should be close monitor and who should be waiting for the next screening. That's why I think we just new with this care pathway, but they have a room of improvement that we can make it together in any stakeholder to involve it.
So we've got to get started with new technologies in this space.
Yeah.
Like new communication technologies as well. I'd like to move forward and look at how ready we are for this. We've seen the numbers. We know the rates of risk factors, obesity, diabetes are rising quickly, and that means advanced liver disease and fibrosis to more advanced disease to liver cancer is really, really increasing. How prepared are we for that across the region, and how are we going to start to recognize that burden is rising very rapidly and be equipped? What are the gaps in that? Faisal, I might bring that to you. I mean, there are obviously enormous gaps that we're not identifying early enough, but at the moment we've got this rising tide of more advanced disease that we've got to be ready for as well.
Yeah, it's something that like I've said, even without this fibrosis agenda on the table, it is already so basically how we can shift it from specialist care to primary care. I think that and primary care, at least in Malaysia, is already overburdened with the current burden of non-communicable diseases. So perhaps one thing that is important, or maybe I know there's not a final message, but you need to get the first people at the policy level to consider it, to talk about it. That means putting it on the policy space, maybe in the NCD policy. You can decide which bit of NCD policy depending on the setup of your country. I think that would be a first step. Second step is how we can look at putting risk stratification into the primary care workflow, depending on what is your chosen entry point. Let's say for Malaysia is diabetes. So whether we can incorporate it into the workflow for a typical diabetes patient. But then again, you are already, patients have to travel between different parts of the systems, right? So if you got detected with a high FIB score, then you need to travel to another facility. How we can ensure it's not just referral, because that's the danger now. Oh, I've done my job. But I do not even know whether the patient have turned up for that next level of screening. And this happens, for example, for my colorectal cancer screening program in Malaysia, because this is two-step screening, right? You do your IFOP and then you do colonoscopy, and patients don't go. So why do you do IFOP in the first place if you know patient is not going to do the scope kind of argument? So it is part of that system. So I would say risk certification and ensure that every high risk results leads to a completed care. If you can't track the patients, then I'm afraid, okay, we're screening more and more, but I'm not sure what's happening to the patients after you screen, because that's the danger in a lot of settings actually when the focus is so much on the screening itself. So is there a mechanism in place to ensure that you can ensure that whoever is high risk completes that the care that is required for them? Digital health can actually facilitate and can help with a lot of this. But then again, there's a separate discussion about the readiness of your digital health in your countries to assist you to do this. Otherwise, doing it manually is very hard to track patients over the different part of the system. I mean, and when they come back and making sure they get their regular screening, blah blah blah. Because for me, it's not just the goal is not just increasing screening. The goal is making sure that if it's high risk, you are able to track them so that they get the care that is required. If you are not even able to track them, or they do not refuse to go to that next level for whatever reason, then we need to see how we can actually address whatever concerns that the patients have. Because I'm personally, Simon, I'm something concerned about the demand side. I think we are too focused on the supply side. That means providing these services, everything, but the demand is not there, especially from vulnerable groups. The ideal patients come to us, but they are low risk. The highest risk do not come for multitude of reasons, which can be different from different countries. These are very context specific. And I think we need that discussion as well when we talk about systems, not just about making sure these are available, but whether when it is available, that the most vulnerable population are actually want it or engage with it and getting what they are supposed, what is due to them as, because they are our population and we're supposed to take care of them, right? It's a shame that we provide the service, but they're not engaged with us. And then,
it sounds like we need investment really to join those dots, to make sure that we're doing the work at the level of the whole population, but then ensuring and knowing whether they're getting through the care pathways that you've outlined. How do we get that investment into the system?
I think one aspect, civil society, strong. I think more and more countries now talking about people with lived experiences and involving them with policy. We in Malaysia, at least I know because I was involved, we hardly do that before, but now we're trying to. So this shift as well, because you need the patient's perspective to make sure that you're aware of that demand side. Otherwise, you're just focused on the supply side, So you need more and more stronger civil society. That's one. But we at the policymaking space need also to ensure that you can create safe spaces for people with lived experiences to have their say, to tell you, yeah, it's nice on paper, but so I need that but, and these are the things that you as policymakers, and I agree with Jacob as well, context matters. So even in Malaysia, I have rural areas, I have the part on Borneo Island, Sabah, Sarawak, which is more rural, more inaccessible. So yeah, so they will need modifications. So while when we do our CPGs are ideal patients, ideal situation, and where settings are not ideal. So we need that modification as well. And that modification needs also input from people with lived experiences and also healthcare workers working in those spaces as well. So it's not, yes, we need a starting point. Agree. A CPG, this document, yes, I agree. But there is also a need to be able to modify and to monitor that your modification is also benefiting. And it's no point just doing it for the sake of doing it without really changing health outcomes. So this way, I think important investment in health, digital health as well. I think that's like I said, another separate discussion. But I see it as a prerequisite moving forward. Otherwise, we will struggle with the old problems that we have. Just adding on another layer of work. And I think a lot of healthcare workers are already overburdened with what they already have.
So, Jacob, I'll take the next one to you, really about data systems, because what Faisal's talking about is we need to know what's going on, and we need to have systems for integrating all of that. How do those data systems look like they're going to evolve to help us manage this crisis?
Well, they have evolved in some parts of the world, and you just need to look at any of the Scandinavian countries. I go quite often to Denmark. They got all pathology comes into one central system. A doctor can see imaging done. This is, I mean, talking from a specialist perspective. Doctors can actually see blood tests, imaging, anywhere done in Denmark for any patient. It's very easy. So the Scandinavians have actually, even before the era of the data systems we've got today, they were already doing it. And it required, extremely good public health informing policy, governments willing to listen, and patients demanding it. So I think there is an example and it can be done. We just need to, I'm not a data scientist myself, but certainly when you look at, most diseases, anything from liver disease to inflammatory bowel disease, or even cardiovascular disease, the Copenhagen Heart Study, many of the Swedish studies, they've done it. And from the data side, I think we can do it if we have the political will.
Thank you. And I think that's a really, really important note to really be ending this discussion on. We've really taken a very wide-ranging look from what we can do from a government policy level, but right down to the individual engagement level, the primary care level, and most importantly, making sure we know what's happening and using the systems that we can integrate in our countries, looking at the data and using them and looking at examples where it's really, really worked. So thank you all for your participation in this discussion. I think it's been very, very important, and I'm going to hand back to Roberta to make some final remarks. Thanks, Roberta.
Thanks so much, Simone. Thank you, all of you, for this rich discussion. So it's very hard for me to summarize. So I will not try to summarize the learnings, because now the paper is available up on our website at the APAC Liver Disease Alliance. I think the link was shared in the chat. But actually the best way to be updated about all our publications and work to come is to follow our LinkedIn page. You can find us at APAC Liver Disease Alliance on LinkedIn, and same thing on Google on our website. So I think one takeaway that I wrote down in my notes during this discussion is that it looks like we have the science, but we are missing political will. We are missing policy ownership, and we are missing the willingness to redesign or at least optimize the system to make sure that people are diagnosed early, but also they go into the care pathway as they should. Yeah. So these points were made many times. So what's next now? I will speak on behalf of the APAC Liver Disease Alliance. As I mentioned at the beginning, we are not going to, publish this paper and move on. We will actually use this paper, which is, I think, close to 200 pages long. So our work will be very hard and I think very meaningful. So we want to bring this conversation that has started today with you into the rooms where local territory level policymakers, clinicians, patient advocacy groups are. Because as it was also mentioned during the discussion, what works in one country cannot be just replicated in another. So just to give you an idea of what this will mean, we already have 3 country roundtables planned for this year. They will happen later this year. We will communicate about that on our social media. And of course, we are also preparing a full program for 2027. And our objective will be to take the very good learning and recommendations from this paper and make sure they are discussed and they become part of an actionable plan in every territory across the Asia Pacific. So the paper is available for you as well. Yeah, so I will put you as part of the next steps. Please do use it in your own advocacy, in your own institutions, and in all the conversation you will have with policymakers and decision makers. And of course, if you have any questions or you want to participate to any of our upcoming work, please do feel free to reach out to us. And thank you very much for being part of it. Very excited for this launch today, and also especially for all the work that will come in the next few years. So thanks a lot. Thank you, Sapan. I will hand it over to you. Thanks.
Thank you, Roberta, and thank you to all our moderators and panelists for a very insightful discussion. Thank you to all the attendees for participating. You have the links, and we hope you found this webinar insightful and informative. Thank you for joining. We will be ending the webinar now. Thank you.
Thank you.
Bye. Thank you.